Hello, my name is Alex Pizzari, and this is my final practical examination video for ATEP 437 at East Stroudsburg University, Advanced Emergency Care and Athletic Training. So I'm going to start out with the first scenario, which is a 16-year-old female who collapses during a soccer game. She is pulseless and not breathing. The AT runs out and immediately starts CPR. Other team members cannot find the AED. No one has called 911. And they don't know the venue address. So what could they have done differently? How can they avoid this in the future? So they should have a detailed EAP that states the location of the AED, who should be calling 911, as well as the venue address in it. And they should be rehearsing this EAP pretty regularly. So what legal ramifications can result from this? So they could definitely be facing charges of negligence, as they all failed to act in an appropriate manner, which could have potentially caused even more harm to a patient that's already pulseless and not breathing, because each minute defibrillation is delayed, the chance of survival decreases drastically. So next scenario is scenario 5. Which is a Friday night football game. One of the refs collapses. He is unresponsive to stimuli, has no pulse, and is not breathing. So the first question is, after assessing level of consciousness and vital functions, what are your next steps? So you're going to want to call 911. You're going to want to obtain an AED if it's available, and then you're going to want to start CPR. And the next couple questions kind of go hand in hand. It's the compression to breath rate for a 2-person adult CPR and how many rounds before you switch. So you're going to give 30 compressions to 2 breaths, and you're going to switch every 5 cycles, which should be about every 2 minutes. And the steps for an AED. You're going to want to place the AED near the patient's head and turn it on. You're going to want to expose the chest and clear it of everything. If there's dirt on it, if there's chest hair, if the person's wet, you're going to want to dry them. Then you're going to peel off the adhesive backings of the AED pads, and the sternum pad is going to go on the upper right, and the apex pad is going to go on the lower left. Excuse me. And then you're going to make sure that the electrodes are plugged in, and you're going to want to analyze the heart rhythm. So during the time when the AED is analyzing the heart rhythm, you're going to want to stop CPR. And should the AED advise a shock is necessary, while the AED is charging, you're going to continue CPR. And after the AED is fully charged, you're going to want to state, "I'm clear, you're clear, we're all clear," to make sure nobody is touching the patient, and deliver the shock. After the shock is delivered, you're going to want to continue CPR, and after 5 cycles, reanalyze. And you're going to repeat these steps until either EMS arrives or the patient regains a pulse. And the last scenario is scenario 4, which is a wrestler who has a history of asthma comes into the athletic training office complaining of difficulty breathing. He cannot speak in full sentences, but he claims his inhaler is working. He's using accessory muscles when breathing. EMS is called, and then suddenly the patient leans back on the table and becomes unconscious. His respiratory rate is less than 10. His oxygen saturation is 88, but his heart rate is strong at 90 beats per minute. So would a BVM be indicated here? And I would say yes, it would be, because what they do is they provide positive ventilation to the patient and keeps their airway open, their lungs inflated, and they are used when the respiratory rate is not high enough to support life, and they can kind of, quote, pace the patient's breathing. Would an airway adjunct be indicated here? I would use an NPA in this situation, because with an OPA, even though the patient is unconscious, they still have a pulse and they're still breathing, so you still have the potential for a gag reflex. I would only use an OPA on an unconscious, pulseless, not breathing patient. even though I find the OPAs more effective. And O2 administration. So yes, as I said, I would start the patient on a BVM, and should the patient either regain like a normal respiratory rate or regain consciousness, I would then switch the patient over to 15 liters of a non-rebreather mask.